Welcome everyone to today's presentation. I picked it up from the pharmacy. What is it? For those of you who are new to Children's Mental Health Resource Center, my name is Jennifer Sevick, CMHRC's clinical director, and I am joined by my colleague Jana Cupp, CMHRC's Director of Family and Patient Education. Our mission here is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and its newly recognized phenotype, thermoregulatory sleep dysregulation disorder, also known as fear of harm or FOH. So let's begin with our learning objectives, which include to explain when and why psychiatric medications are commonly prescribed to children and adolescents, to identify what the benefits and risks of three classes of medications, and to describe what it means to partner with a provider as an informed decision maker rather than someone who just signs the forms.
It's our last objective that really gets at the heart of what we're here to discuss today. We want you to be informed, not alarmed, not talked into anything or out of anything, but a fully informed participant in the prescribing process.
And as we go through this presentation, please put your questions in the chat or Q&A, and our colleagues will be able to answer the questions in the background, and we'll save some common ones for the live Q&A at the end of the presentation. So before we get into the content, I want to make clear that this webinar is for parents and caregivers who want to better understand the psychiatric medications that may be prescribed to their children or that have already been prescribed. We're going to talk about antidepressants, antipsychotics, and mood stabilizers, what they're used for, how they work, what to watch for, and how to have better conversations with your child's provider.
That's right, Jen. And we want to be equally clear about what we're not doing tonight. We're not giving individualized medical advice. Nothing here is a recommendation for what your child should or shouldn't take. That decision belongs to your family and your prescribing provider together. We're here to make you better equipped for that conversation. And honestly, that's enough. You don't need to become a pharmacologist or a pharmacist. You're already an expert in your child. You just need more confidence so that you can ask the right questions. And that's what we're building tonight. Okay, so we're going to start out by talking about what the purpose of a medication is in a treatment plan. The National Institute of Mental Health puts it this way. Medications can play an important role in treating mental disorders, and they're often most effective when used in combination with other treatments like psychotherapy. The key is working with a provider to develop a plan that fits the individual child's needs.
So, not the medication instead of therapy, what you're saying is alongside it.
Exactly. Medication is only one tool that we have available to us to support our mental health. When you use that tool, it works best when used with all the others in the toolbox. Tonight specifically, we're just going to talk about that one tool. And I want to be direct about something here because it's really important that parents hear this. Medications are not a cure for mental illness. They are not going to make the disorder go away. But for mood disorders like bipolar disorder and major depression disorder, they're often critically important for the management of the illness. Many people living with these conditions benefit significantly from pharmacological support as part of a broader plan, which means they overall end up with fewer hospitalizations, better daily functioning, and they get to spend more time in school as kids. Psychiatric medications are medical treatments, full stop. And medication decisions are joint between the family and the provider. Remember, we're here to share information, not to tell any family what their child should or should not take. That choice belongs with the family.
Jana, can you talk a little bit more about what psychopharmacological actually means?
Yeah, it is a really big word, but in plain language, it's just the science of choosing, prescribing, and managing medications that affect the brain and the body to reduce symptoms like depression, anxiety, mania, or even psychosis.
Yeah, I think a lot of people, when they hear the term psychopharmacology, probably think that it's all about pharmacists.
The words are similar, so it makes sense that you would make that connection. However, pharmacologists are not pharmacists. Pharmacologists are research scientists who research on drugs in laboratories and clinical trials to help develop safe and new and effective medications that then pharmacists can dispense. Pharmacists are highly trained professionals and medication experts. They ensure that your prescription is going to be safe, effective, and appropriate for your needs. They are able to educate patients on proper usage, potential side effects, and interactions. And they collaborate with your doctors to help you manage your health. And for doctors who do the prescribing, such as psychiatrists or nurse practitioners or even physician assistants, they also have specialized training in medications. So think of it this way. The researchers back in the lab figuring out how the drug works, that's our psychopharmacologist. The providing prescriber is the one sitting across from the patient asking, okay, but which drug, at what dose, what's safe for this person? Then you go to the pharmacy and the pharmacist reviews that prescription and then will prepare and dispense the medication to you and provide you all the additional information you need when you pick up your prescription.
But how do we know if one patient will respond to medication the same as others who have taken it?
Well, we don't exactly know, but there is a field of study called ethnopharmacology that explores how genetics and cultural influence the way people respond to different psychiatric medications. Things like ethnic background, lived experience, environment, history, all of this can affect how well a medication works and how well a person can tolerate the medication. It's a very rich and complex field of study that's deeply personalized.
So, I want to talk about medications and what they are actually designed to accomplish, because I think this helps set realistic expectations for both families and clinicians. I think most families would agree with me that the primary goal is to reduce the intensity and frequency of these symptoms their child is experiencing. When a medication is well matched to a child's presentation, the results can be really meaningful. They see this increase in quality of life. There are fewer hospitalizations, less time missed from school, and improved overall functioning across environments. But the key here is when the right medication targets the right symptoms, things get better.
Yeah, but you have to remember that finding the right medication is usually a process. It's not a single decision. It often takes time, multiple trials of different medications, and patients from everyone involved. Psychiatric medications can also take several weeks or even months before noticeable improvement occurs. It's not like taking a Tylenol and having your headache go away. And if something seems like it's not working, or it's causing side effects that feel unmanageable, the right move is to always loop in the prescribing provider rather than stopping the medication on your own.
What are we actually hoping the medication accomplishes beyond just having a few bad days?
Well, overall, the goal is mood stabilization. This means that a child's moods are going to stay more steady and balanced. And this will help reduce the severity of the extreme highs and the extreme lows.
Providers aren't looking for the child to feel perfectly happy all the time. Is that correct?
Correct. They're definitely not looking for that. What we're looking for is consistency over time. So fewer clinically significant mood episodes and an improved ability to function in their daily life. That signals that something's working. And for families, their observations about how the child is sleeping, how the child does at school, if they're engaging with their friends, all of that is critical clinical information. It really matters, and the prescriber needs to hear about it. But there's no medication that's going to make it so we have perfectly happy moods all the time.
You mentioned the word episodes. Can you talk more about how medication helps managing disorders more generally?
Yeah. So I really do feel strongly about communicating the importance of this. Mood disorders, they're cyclical, so they fluctuate over time. Many people with right treatment and the right support have long stretches of stability, and it's fantastic. But even when you're doing everything right, there still can be breakthrough mood episodes. So it's really important that we try to minimize the episodes beyond whatever is happening in the moment. And this is really important because of something known as the kindling effect. Dr. Robert Post from the National Institute of Mental Health has published a research showing that repeated mood episodes, so having more cycles, means that each untreated mood episode makes the next one more likely and potentially more severe. So the medication isn't just about managing today, like when you take a pain medication, but it's about protecting the brain over time from this pattern of episodes and cycles that actually makes it worse.
Yeah, that's really such an important reframe. So stability isn't evidence that the plan isn't needed anymore.
Stability is actually evidence that the plan is working. And that's a huge distinction. Just because the symptoms are going away and they're being controlled doesn't mean that it's time to come off the medication. Oftentimes, that's when kids start refusing medications, and you might, as a parent, start questioning it. But this is actually when it's working.
So I'd like to point out at this point in the presentation that a lot of families from communities with histories of medical mistreatment, including Black and Indigenous communities, often approach medical or psychiatric recommendations with skepticism. And this is really understandable. And the uncertainty is driven by a very valid acknowledgement that the medical system did not have their best interests at heart. That deserves honest acknowledgement by providers and patients and their families. But it doesn't mean that there may not be a benefit to medication for members of those communities.
And for those families that might be in that position that are here with us tonight or watching this, we do see you holding the complexity of that and still getting your child the care they need can feel like it's in conflict, but both can be true at the same time.
Okay, Jana, before we get into talking about specific medications, can you address a question that comes up constantly from families about medications? What's the difference between brand and generic medications?
So basically, the biggest difference is that when a medication is first made by a pharmaceutical company, they're under something called patent, which means nobody else can make a copy of that medication. So this makes those meds very, very expensive. But this patent or rule against having other people make it only lasts for a few years. So once the time is up on it, other companies will make their own versions of those medications. And we typically call those generics. And they're usually a lot less expensive. Generic medications are required by the FDA to have the exact same active ingredient and the same dose as their brand equivalents. So for most people, generics work just as well and they cost significantly less. But same doesn't mean identical in every respect. And it's worth being honest about that.
So, what is the difference then between a brand and a generic medication?
We can see the difference in the inactive ingredients. So this is things like fillers, dyes, or coatings. Those don't change the primary mechanism of the medication, but occasionally it might impact how the medication is absorbed by the body, or some people might be a little more sensitive to some of those fillers. Generics are often manufactured by multiple different companies at multiple different facilities, and pharmacies switch suppliers without telling you because they're trying to get the most cost-effective one. And for some extended release formulation, that coating on the outside that delivers the medication slowly over time, that usually is harder to replicate exactly as a brand does it.
So, the practical takeaway here is that generics are generally a safe and cost-effective choice. But if your child switches from a name brand to a generic, or even one generic to another, and you notice a change in how they're doing, so are you saying that's worth mentioning to their prescriber?
Yeah, I wouldn't be alarmed if that's something that you're seeing. And it has to be not just that you've switched the med, but that there's a change in how your child's presenting. That is definitely worth a phone call. There could be an alternative medication that can be prescribed, including the brand name.
Let's now get back into the specific medication types. Jenna, can you start talking about antidepressants?
Yeah, antidepressants at their most basic is any drug that is administered to treat depression. Pretty straightforward. However, clinical applications of antidepressants go beyond depression alone. And we're going to walk through those in a moment. But I want to start with pointing out that there are different types of antidepressants. The most common and the first one is called an SSRI. This stands for selective serotonin reuptake inhibitor. They work by increasing the amount of serotonin available in the brain, and you likely have heard of many of them. Sertraline, which is known by the NAM brand of Zoloft, is one of the most frequently prescribed. Beyond SRIs, there are two other classes worth knowing. SNRIs, which stands for serotonin norepinephrine reuptake inhibitors, which work really similar to SSRIs, but you get both serotonin and norepinephrine targeted. And some of those are like Cymbalta or Effexor. Then there are the atypical antidepressants, which is like a catch-all category from everything else. And they all work through different mechanisms, which are typically a little different from SSRIs or SNRIs. And these are usually selected after trials of SSRIs or SNRIs haven't been effective or well tolerated. You're looking at medications like Wellbutrin or Nardil in this class. So I do want to flag one category here, the tricyclic antidepressants. These are a part of the atypicals. Torafenil in particular, and its generic name is imipramine. The Pediatric Pharmacy Association's 2025 Kids List, it's an evidence-based list of meds that require special caution or avoidance in kids. It classifies tricyclics at avoid in all children and adolescents because there is an increased risk of cardiac death. While that sounds very, very terrified, all this means is that sometimes if this is a medication that needs to be prescribed, the clinician and the family needs to understand the risks and the benefits before deciding to have the medication. So it's worth a discussion with your provider.
Okay, so this list of antidepressants are medications that work for depression, but what else can they do?
So as I said, they work for a lot of different things clinically. So you're going to see them commonly used for anxiety disorders like panic disorder, social anxiety disorder, separation anxiety. And they're a first line choice for those because the side effect profile of these medications is very, very favorable, meaning you're not going to have a lot of side effects. They're used for major depressive disorder with a seasonal pattern. This is what is more commonly and formally known as seasonal affective disorder. They're often even sometimes used for ADHD, and that's typically when first line treatments haven't worked or weren't suitable for the child.
Okay, but when a child starts an antidepressant, families often want to know how long before they're going to actually see results or their child is getting better.
It really does take time. Often providers won't want to reevaluate effectiveness until about 6 to 8 weeks have passed since starting the medication. And that's when the providers are able to better see if the medication is providing a meaningful therapeutic benefit and not even just the full therapeutic benefit. We're just looking for initial changes at 6 to 8 weeks. Unfortunately, this means that finding the right medication often takes more than one try, and it can take a long time. And the reality is that's just how this process works. And I want to be really clear about one thing. It is extremely important to never stop an antidepressant abruptly without guidance from your prescribing provider. Abrupt discontinuation can trigger something called discontinuation syndrome. And these symptoms include things like flu-like symptoms, dizziness, irritability, mood swings, and everything that might look like the original problem just coming right back. You always need to work with your provider to safely taper off a medication and to determine the best course of action if you need to stop the medication.
Okay, that's a good segue to talk about what side effects might be able to be seen, which is one of the areas where families really feel like they're caught off guard.
Yeah, it can be easy to get caught off guard to go from your doctor's appointment to picking it up at the pharmacy and getting that long package insert. It's really hard to read. And for most people, the great thing though is side effects are mild and they tend to improve within the first weeks of treatment. So they're not as terrifying as they sound when you're looking at that pamphlet. Typically, the side effects, they're annoying, like an upset stomach when you take the pill, maybe some dry mouth, a little constipation, maybe some dizziness. For some people, it's activating and they get a little insomnia. Others are drowsy and sometimes some increased anxiety. But these, they're pretty easy to manage. And a simple change like taking your medication with food or talking to your provider about switching the time of day you take it to manage that activation and extra energy or the sleepiness. Usually that's all it takes to resolve it.
Yeah, those really do sound annoying, but you can usually get through those if the medication is helping. But you had noted that increased anxiety, medications make anxiety get worse.
They can, and it's a really real phenomena called the activation effect. It's not uncommon in early treatment with an antidepressant to see a little more anxiety. It often settles down within the first couple weeks. It can be really distressing to see happen because you were hoping that this was going to get better. But if you do see it happening, know it is a known thing to happen. And if you do see it happen, communicate to your provider. Typically, it's not severe and everything will move on and it's fine. If you do see it more severe or it's not resolving, that's going to be important clinical information. I also want to flag on the side effects here something called serotonin syndrome. It is rare, very rare, but it can be serious. What happens is that if you have multiple things that are raising the serotonin levels and they're combined, this can cause serotonin syndrome. Some of the things that might raise your serotonin levels might surprise you. These can be supplements like SAMe or St. John's wort, certain migraine medications, and a lot of the anti-nausea medication. So it's really, really important to tell your doctor and pharmacist about every medication, every supplement, every vitamin, every single one that your child is taking. The pharmacist is a genuinely underutilized resource. Even if you skip that consultation at the counter, there's usually a phone number that you can call for consultation after pickup, and it's worth a few minutes of your time.
Along similar lines, can you explain what a box warning is?
Yeah, a boxed warning, and this is formally known as a black box warning, so that might be the language you're more familiar with. This is the highest safety warning an FDA can assign to a medication. I know that sounds alarming at first, but what you need to know is that these warnings are designed to bring attention to the most significant risks known of an entire class of drugs so that they can be added, updated, and removed over time. So this changes all the time with new research. And to date, about 400 medications currently have them. Those box warnings, since they apply to a whole class of medication, it's not specifically to the one exact medication that your child's been prescribed. It's not meant to be an absolute prohibition. It's not meant to say never prescribe this. What it's meant to do is to flag the concerns so that the clinicians and the pharmacists and the families can really weigh the risks and determine what monitoring is appropriate for taking this medication. Providers use their clinical judgment when weighing those risks and benefits to that individual patient. And families can use their judgment and weigh whether or not to take these medications.
So then the box warning doesn't mean don't take it.
Now, the box warning means take it with your eyes open. Know what you need to monitor and watch for. Ask your prescriber, what are you looking for specifically? A warning on your child's medication means the provider made a clinical judgment call that the benefits of this medication are going to outweigh the risk. And what this means is that you just need to monitor.
So let's move on now to antipsychotics. And I know this is a word that carries a lot of weight for families just to hear the word antipsychotic.
Yeah, it does. And that has to do with the stigma around it. But it's important to know that the APA defines antipsychotics as any pharmacological agent used to control symptoms of things like schizophrenia and other disorders that may have characterizations of impaired reality testing. And this looks like disorganized thought, speech, or behavior. And the clinical applications of antipsychotics go way beyond this very simple definition.
So, what are they actually prescribed for?
So there's schizophrenia, which is the most common one that people think of, but it's also prescribed for bipolar disorder, mania, major depression with psychosis, delusional disorder, really severe agitation or very severe irritability, borderline personality disorder, dementia, delirium, substance-induced psychosis, even Tourette's and OCD can be effectively prescribed for antipsychotics. And so while they're primarily designed originally to treat psychosis, we have a lot of clinical applications for these medications.
That's really quite a big list. So, a child could be on an antipsychotic and it has absolutely nothing to do with psychosis.
Yeah. And a lot of families will see that label of antipsychotic and think, but my kid isn't psychotic. But that's not unusual at all. The medication could be targeting the severe agitation, the mood instability, or a completely different set of symptoms. The name's not the full story.
I have heard psychiatric nurse practitioners and doctors say this is a first generation antipsychotic, or this is the second generation antipsychotic, or even the next gen. What does that all mean?
So there are three main generations, and there are some differences. So it is important to kind of understand them. Our first generation antipsychotics developed in the 50s and the 60s include things like Halidol, haloperidol, thorazine, chlorpromazine. These are the ones you're probably going to most commonly encounter today, and they work by blocking dopamine receptors in the brain. They are extremely effective for psychotic symptoms, and they have a higher risk than the other categories of movement disorders. So you might notice changes in gait or like this inner restlessness. That's called akathisia. And in some cases, a rare but severe side effect could be tardive dyskinesia. This is repetitive and involuntary movement, and it might be permanent. We need to catch these signs and symptoms of movement disorders early. While they're not very common, if we catch them early, they can often be reversed or managed with medication.
Okay, so that's the first generation, but what about the second generation then?
So second generations were developed in about the 1990s. These you probably hear a lot. Abilify, risperidol, Seroquel, Zyprexa. They are the most widely prescribed. They have a much lower risk of any movement disorders compared to the first generation, but they do come with a trade-off. They often have metabolic syndrome and symptoms that come on with it, and we can talk about that in a few minutes. The newest generation, Vraylar, which is known as cariprazine, and Rexulti, which is Brexprazole, were both approved about 2015, so a little more than 10 years ago. These work a little differently from the simple dopamine blocking because they function as partial agonists. So this fine-tunes how the brain uses both the dopamine and serotonin. The goal of this next gen is to preserve the effectiveness of medication while reducing both the movement side effects of first generation and the metabolic side effects of the second generation. And so far, they do just that.
So, can cost be an issue with these?
A real one. Both of these are not generic available. So it's brand only for these because they're still under patent, which means nobody else can make them. So they can be considerably more expensive. And this is a legitimate factor when deciding treatment. You can and should ask your child's provider about cost when medications are being recommended.
What can families expect to see, and when can they expect to see it?
So it really depends on what symptoms are being targeted with the antipsychotic. Something like agitation and hallucinations often begin to improve within hours or days of starting a medication. Other symptoms improve more gradually. So how long a child stays on an antipsychotic is entirely individualized. It depends on the symptom presentation, it depends on their tolerance, response, and the long-term treatment goals. It's worth noting, though, these medications are truly very, very effective, and they can be very difficult to manage life without them. So for many children with severe presentations of symptoms, they make it possible for them to function in daily lives in ways that would other be extremely difficult.
The side effect I have heard families most blindsided by with antipsychotics is that weight gain. So, can you take a moment to talk about what's actually happening here?
So it's important to know it's not just weight gain, but that is the most physical representation of it, which is why families see it. But it's actually metabolic syndrome. And the numbers are really significant. And this is for our second gen antipsychotics more than any other generation. And it occurs in approximately 30% of patients. The risk is even higher if you're under 16. The metabolic syndrome includes a collection of symptoms such as weight gain, high blood pressure, elevated cholesterol and triglycerides, high blood sugar, fatty liver, insulin resistance, and this overall increases the risk of diabetes. And you don't even have to get them all. You may see 2 or 3 in a child or all of the above. It is a serious longitudinal health concern, not a minor side effect.
So, what you're saying here then is monitoring is really non-negotiable.
Monitoring is the key to making sure that we are making sure these kids do not have to have these long-term consequences of the medication. So this looks like regular blood work, regular physical check-ins. It has to be part of the plan. If a provider hasn't talked to you about monitoring when they're prescribing second generation psychotics, it's worth asking about directly.
Can we now shift to mood stabilizers? What are they and how are they different from everything else we just covered?
So mood stabilizers are medications used in the treatment of cyclical mood disorders. So the things we've been talking about, like bipolar or cyclothymic disorder. There are 2 main classifications. You have lithium in its own class and anticonvulsant medications. You might have heard them called anti-seizure medications or anti-epileptic medications. These are the mood stabilizers. While other medications can support mood, technically, these are the only 2 categories under this classification.
Yeah, I want to be sure I understand this, although antidepressants primarily target symptoms like depression and anxiety with mood improvements as a benefit, but they aren't designed, what you're saying is for long-term mood stabilization in the way mood stabilizers are. And then you have antipsychotics that they can help with mood symptoms, but their primary role is managing psychotic symptoms or acute mood episodes or agitation. But mood stabilizers like lithium or valproate are indeed a class specifically designed to present mood episode cycling, both those highs and those lows over the long term. Do I actually have that all correct?
You do. That is the clear separation of each of the categories. So you can see how a treatment plan might include multiple things, because they're each kind of targeting different symptoms. Mood stabilizers are so effective at maintaining that mood stabilization over the long term. But they are used for things beyond just bipolar and cyclothymic disorder. They can be used for schizoaffective disorder, major depression disorder, and PTSD. Again, like the other medications, the approach in prescribing is symptom focused. The medication targets shared features like mood instability, emotional dysregulation, regardless of the specific diagnosis in the chart.
So I hear so much about lithium, and it is really considered the gold standard in treatment for things like bipolar disorder. Why is it the gold standard, and what is important to know about lithium?
This is such a great topic. Lithium is one of the most studied medications in psychiatry. It's been a first line treatment for bipolar disorder for decades. Dr. Robert Post and colleagues have described it as a disease modifying treatment, not just something to manage symptoms. And research shows it improves the long term illness trajectory, providing neuroprotective benefits, and it may actually reduce the progressive decline over time. So we've moved beyond just suppressing symptoms with lithium, and we may actually be changing the course of the illness.
You said neuroprotective. Can you say more about that?
Yeah, so what it means is that lithium can prevent brain cell death. It appears that it protects those neurons, those specialized brain cells, from damage or even prematurely dying up. There's also evidence that it promotes brain cell growth. So it's stimulating the production of the proteins that help those cells in your brain survive and thrive. We also know it reduces inflammation in the brain. And some studies even show that people on long-term lithium actually maintain more gray matter in certain brain regions compared to those not on it. And I think it's one of the things that makes lithium stand out is these neuroprotective properties. Research strongly suggests that it's helping protect the brain long term. And that's really remarkable for a medication.
You know, that's actually really incredible because that's no small distinction of what you're talking about. No wonder why, with this neuroprotective factor, it's considered the gold standard for treatment. So, but then what it makes me wonder though, Jana, is what is the catch? All medications have risks and benefits. And I hear prescribers that are really nervous when prescribing lithium. Can you share more about that?
Yeah, a lot of prescribers can get nervous about prescribing lithium typically because they just have less experience with it. Even though it is gold standard, lots of people are reliant on the other classes, especially the antipsychotics, which are newer. Lithium does have what's called a narrow therapeutic index. This just means that the range of safe and effective level in the bloodstream is very narrow, like small or short, than most other medications. Basically, if the level is too low, nothing's going to happen. You're going to get no benefits of the medication. But if it's too high, it can become toxic. And that's why you have to monitor with regular blood draws. This is not a formality, it's how we safely manage a really great medication. Providers will start patients on a very low dose and routinely draw labs and then slowly increase the dose until they achieve not only the symptom improvement, but also the blood level in the therapeutic range, which is about 0.8 to 1.2 milliequivalents.
So, doctors and other providers often have concerns about lithium toxicity. Can you speak on that?
Yeah. So lithium toxicity makes people very, very scared. I mean, the word toxicity tends to make people concerned, understandably. But most commonly, this rare side effect will happen if someone's taking lithium and not maintaining adequate amounts of salts like sodium or water. This leads to dehydration, even something like having a GI illness, like if you're vomiting or having diarrhea, that can make you really dehydrated. If you've got heavy exercise, or if you have a significant dietary change that shifts that salt and the water in your body, that can shift your lithium levels. The good news about this is because it is based mostly with salts and waters, it's really preventable. And all you really need to do is understand what the signs and symptoms are and that you need to have enough salt and water. So those early symptoms that you might look for include a coarse tremor. This is very different from that little fine tremor that's more common. You'll also might see some nausea that's a sudden onset, intense diarrhea, and some confusion. But as I said, if you know what to look for, you can catch it early. If you are consistently monitoring the blood levels, you know exactly where your child's at, and so does the provider, then lithium is absolutely worth considering. There's a lot of growing research supporting its long-term benefits for brain protection, and making sure that you're hydrated is a relatively easy fix.
So, Jana, are there any other types of mood stabilizers that we should be talking about here?
Yeah, that's the anti-epileptic, anticonvulsant medications. Common examples that we see are triliptal, which is oxcarbazepine, tegretol, which is carbamazepine, and lamictal, which is lamotrigine. All of these were originally developed to treat seizure disorders, and now they're approved for mood stabilizers. And they're actually pretty commonly prescribed alongside lithium. So you have lithium as the base, and then these added on. Just like lithium, their levels can be monitored through blood work.
So, we've talked about lots of benefits of mood stabilizers, including reducing the frequency of these mood episodes that you've been talking about. supporting mood stabilization, and then playing a preventative role in reducing relapse. You also mentioned, Jana, that there is an emerging evidence of neuroprotective properties, meaning some mood stabilizers may help preserve healthy brain functioning over time.
You've got it, Jennifer. But we do have to be aware that there are potential side effects for these anticonvulsants, like all medication. Most side effects are mild and they resolve after the few weeks when you adapt, and they're easily managed. Again, they're the annoying things like an upset stomach. And of course, taking it with food can kind of help do that. We do notice people kind of complain about some cognitive side effects, so things like memory difficulties or slowed thinking. But I want you to keep this in perspective. Untreated depression, untreated mania, both significantly impair cognition in their own right. And so for many people, a stable medicated baseline actually results in clearer cognition overall than the alternative of that rapid cycling through episodes. Cognitive side effects, yeah, they exist, but you need to weigh it against the cognitive cost of the illness itself and those untreated episodes over time.
Yeah, so to be clear, then Jenna, what you're saying is both depression and mania can significantly impact a child's ability to think clearly, or any person's ability to think clearly. And it seems like while some mood stabilizers may cause some mild cognitive blunting as a side effect, what you're saying is that most patients actually experience better or overall thinking once their mood is stabilized, because it seems like their brain is no longer overwhelmed by these extreme high or low episodes.
Yeah, that's exactly right. I think it's also we should note that with the mood stabilizers, many of them interact with medications like NSAIDs. So this is things like ibuprofen or Advil. They also interact with certain antibiotics and other psychiatric medications. So again, my reminder, please, please, please tell your pharmacist and your prescriber everything you're taking over the counter and otherwise. And you need to make sure that you attend regular monitoring appointments.
Yeah, can you take a moment though to just share about monitoring as a concept? Because it runs through all three of these medication classes.
It does. So for the medication like lithium or anticonvulsants, regular blood testing confirms that those levels are in a therapeutic range, high enough to be effective, not so high to cause harm, that like nice little sweet spot. But monitoring also is really important overall because people with mental illness are statistically at a higher risk for physical health conditions that go undetected. So across a lifetime, this can kind of catch up to them. Regular monitoring allows us to catch these broader health concerns early, and it makes sure the medications are managed safely over time.
So, how do families then and prescribing providers know exactly which medications to try first? Because this is a question that I hear consistently. It feels like, to be honest, for a lot of families, it just feels like a guessing game of what to try.
It can feel that way, but it actually is not random. It's actually just really complicated. Prescribing decisions are guided by how your child presents, your family history. Sometimes medication response has a genetic component. What previous medications have been tried, current medications, possible interactions with supplements. So it's really important that you are communicating with your provider and the pharmacist, all that full picture, so that you can really get a good, solid baseline of where you want to start and what makes the most sense for your child. Additionally, the standard approach with pediatrics is to start low, go slow. This means that your child is likely going to start on a low loading dose. And over time, through those follow-up appointments, when they're assessing how your child's doing, they'll gradually increase the dose until you get a therapeutic benefit.
So, if a family feels like the first dose their child was given seems tiny, that's probably then intentional, correct?
Yeah, your provider's not trying to be timid or anything. It's just an evidence-based way of pediatric practice to ensure more safety. It also lets the body adjust and makes it easier to recognize and manage any side effects that may arise. And we're able to notice the subtle therapeutic effect that's happening and target the lowest dose necessary to effectively treat the symptoms. We don't want to give them more medication than they need.
Yeah, this is probably another reason why monitoring and management is really necessary to be ongoing.
Yeah, that monitoring is so key and why those follow-up appointments are really important. We want to ensure that the improved functioning and quality of life is achieved through fine-tuning the dose. This follow-up visits, even if they seem like they happen a lot, allows providers to assess, does the medication work? Do we need to adjust the dosing? How are the side effects possibly? Are there any new drug interactions? Missing those appointments can create real gaps in care.
Jana, what role do parents, caregivers, and patients have in monitoring between these appointments with providers?
A huge role. Those people are the experts in their child. So between psychiatric appointments, parents and caregivers, they're the most consistent person observing and interacting with your child. So it's might be worth considering tracking sleep patterns, appetite, weight changes, energy levels, mood, and even physical symptoms like tics or headaches or, if their stomach gets upset. You can also pay attention to things like academic performance and social functioning with their peers. All of this is really meaningful because any of these behavioral changes also reflect the underlying psychiatric condition and are important information for the provider.
All right, let's talk about informed consent because I think the concept sometimes gets collapsed into just sign the form and go.
It is so much more than just a form. Informed consent is actually a legal requirement and an ethical cornerstone of medical practice. Your prescribing provider is required to explain the diagnosis when they know it, the purpose of any recommended intervention, and the burdens, risks, and expected benefits of all available options. This also means the option of not treating with that medication. The last part is required. And you have the right to hear what the landscape looks like without the medication, alongside the option of what it looks like with the medication.
And if you leave an appointment without fully understanding what was recommended, then
Go back, make another appointment, make a phone call, send a message in your portal app, ask for more information, ask for more time to make a decision. Don't let anyone tell you that you're being difficult if you do that. What you're doing is being an active participant in your child's care, and that's what you're supposed to do.
I think a lot of families, though, feel like they're supposed to defer to the expert. I mean, that's why they're going to see them in the first place.
They are going to see an expert, but parents are true experts in their child, and they have a lot of power here, and they may not realize it. Parents are allowed to ask for specific medications to be considered in the plan if you've done some research. You can request that providers coordinate care with each other. You are allowed to take time before deciding to use a medication or not. And you have the right and the responsibility as your child's parent and caregiver to decline any medication that you are not yet comfortable with or don't yet fully understand.
And that's not obstruction.
No, you're not obstructing them. The care team wants and needs you to be engaged. A family that's informed and asking questions is not a problem to manage. It means they're a full partner in treatment.
What about second opinions then? These are also ethically supported and legally protected, are they not?
They are very underutilized in psychiatry, but they are an option.
Well, but sometimes a first opinion is hard enough to come by, and then a second opinion may not be so easy to access.
Now, these barriers are truly in the way. It is really important to recognize and state that they're there. There are only about 14 child and adolescent psychiatrists per 100,000 children in the US. Wait times are long. Insurance coverage for second opinions also can be more limited. So, it can be difficult. I know families also worry about being perceived as difficult. It's really important to know that seeking a second opinion should never jeopardize the patient provider relationship and that a professional may not end a patient-physician relationship just because a family decided to seek another opinion.
Well, and that fear about being perceived as difficult that you mentioned, especially by families who've already experienced really feeling dismissed when they're mentioning these symptoms, that's real.
It really is. And the fear is based in the fact that there is bias. It does exist. And it's important to stay clear that when you want a second opinion, it's not going to jeopardize your relationship with the current provider. If that does happen, that for you should be a meaningful piece of information about that provider.
Okay, so let's be very concrete for a moment. What are the situations where a second opinion is most warranted?
So you may want to pursue a second opinion because you need more diagnostic clarity. So some physicians or nurse practitioners are more focused on certain disorders than others. You might want to try a new intervention or think that the treatment plan your child's on needs some adjustment. You might be uncomfortable with a recommendation or sense that the provider isn't really a good fit for you or you're not feeling heard. You might have some concern that there might be bias implicit or outright that are influencing this assessment, or you might just simply want another perspective. You don't have to justify any of these reasons, but these are really great reasons to pursue a second opinion. Fundamentally, determining whether or not a child needs a psychiatric medication and whether or not your child should take them is an important decision for any family, and it needs to be made in collaboration with trained mental health care professionals. For families, understanding the risks and benefits associated with all these medications is essential for them to make an informed decision.
Of course, that is why we host events like this to provide fact-based, research-backed information for families to support them in these conversations with their providers. And no matter what you decide as a parent or caregiver, remember, you're not alone and we're here to help. Thank you for joining us. The next few slides includes the work cited in the creation of this presentation. All right, now we'll move into our Q&A.